I'd like to talk a little bit then about the NICE guidelines. So the NICE guidelines are guidelines. I have guidelines for treatment of every infectious disease in my hospital, and I follow those guidelines. I put people on treatment for the shortest period of time, but guidelines are guidelines, and historically, patients with Lyme disease have been denied longer treatment because the guidelines say you can't treat longer. However, the guidelines for cellulitis say you should only treat for 7 to 10 days, and we treat all the time for weeks and weeks and months for certain patients with certain conditions such as lymphedema, where they don't clear out their cellulitis very well. We do that because we evaluate clinical response. So I have many patients who are offered 3 weeks of doxycycline, they get better on the doxycycline, and then they get worse again after the treatment. And these are patients with classic Lyme disease, the rash, put on doxycycline, got better, and then they're told at the end of the 3 weeks, you can't get further treatment because even though you got better on the treatment and now got worse because the guidelines say otherwise. Now recently the guidelines for NICE have changed. They used to say 2 weeks of treatment. The American guidelines still say just treat for 2 weeks, but the NICE guidelines have changed to say offer 3 weeks of treatment, and I won't go into the actual details of the treatment, and then if patients are getting better or not responding, can switch to another antibiotic and consider another 3 weeks of treatment. So the rash is diagnostic, you should treat automatically, you should use your clinical judgment. A 21-day course is recommended. A negative test does not exclude the diagnosis. And we understand that this is a very confusing area, but the reason it's confusing is because ever since 2005, 2007, where the Infectious Disease Society of America came out with guidelines on treatment, nothing has really changed. There's been no incorporation of new studies and new science into UK guidelines, Irish guidelines, American guidelines. So we're stuck in a time period where back in 2008, IDSA said that if you're still sick after 2 weeks of treatment, then it's post-treatment Lyme disease syndrome, PTLDS, implying that there's no longer a residual infection. And as stated before, I'm not that smart. I can't look into patients' tissues and see if they're still replicating Borrelia, just like I can't look into my sexual health patients and see if there's replicating syphilis. We retreat patients with syphilis if the antibody test is not going down because we think there may be residual bacteria. We should be giving patients longer course of treatments if they respond, especially if they respond to treatment, and when you stop the treatment, they relapse. This implies an antibiotic effect. We always argue that this is an immunological effect of antibiotics, but this is just an excuse being used to deny patients treatment. So we understand that the evidence base is poor, and we do recommend better research and new research, but it's hard to do research when there's so much resistance to do research in the medical community. So there is really poor understanding of tick-borne infections, both in GPs and in UK specialists throughout the European Union. There's no specialist clinics available. There's no provision of a safety net for patients with chronic symptoms. Classically, in studies out of Johns Hopkins, where they have a group of patients who are Lyme positive based on classic ECM rash, the rash, classic antibody positive, who get the standard course of treatment. 20% of these patients remain sick for months and months, if not years and years following it. They have assessments done by quality of life, they don't get better. They actually have PET scans done, and the PET scans have shown abnormalities in the brain of these patients. So there is a chronic inflammatory infectious process going on in many patients, and the NICE guidelines are an improvement over previous guidelines, but I prefer to treat patients, not guidelines.